Hello, I am Bevra Hahn, and I'm a rheumatologist at UCLA. Today I'm talking about lupus, and I did a little bit of history going from the time before we had cyclophosphamide or mycophenolate or azathioprine or biologics to treat lupus and bringing it up to date. So one of the important things that happened in the past was the ban against kidney transplants in lupus patients was lifted in the mid-70s. Before that time, the nephrologists and surgeons weren't allowed to transplant somebody that had lupus because experts knew that the lupus would recur in the transplant kidney. And in fact, that only happens 3% of the time. And now they're transplanted, as you know, like everybody else. Another thing that happened that improved our care was a lot of government legislative advances that included the introduction of Medicare and Medicaid and surgery, insurance for emergencies, and the CHIP program for children, and the Affordable Care Act or Obamacare, and altogether about 1 in 3 Americans are covered by a federal program for their health care, and that's allowed us to really expand the number of people we can treat. And of course, there's been improvement in how we treat patients. There's been the introduction of cyclophosphamide and mycophenolate for people with serious lupus and people with lupus nephritis, although they are not approved by the FDA yet, and neither is azathioprine. But we all use them and we know how to use them, and mycophenolate is coming up to the top as the first choice of many people for patients who have serious life-threatening lupus. And that's because it is as effective as cyclophosphamide but easier to tolerate, and it's effective in all races, and the same thing can't be said for cyclophosphamide. And there's recent data that might be a little more effective than azathioprine. So it's in wide use. And then, of course, belimumab has come in, and we know that people with arthritis and skin disease particularly improve on it. About 60% of people improve. We now have the subcutaneous form, which is going to make it so much easier for patients to use. And looking toward tomorrow, there are a lot of exciting things coming along that look very good in lupus in phase 2 trials. And one of them is an antibody against the interferon type 1 receptors. It's called anifrolumab, and it looked very good in a phase 2 trial. Another one is voclosporin, which is a new calcineurin inhibitor that's supposed to be safer for the kidney. And by the way, tacrolimus plus mycophenolate together looked really good in the Chinese study in terms of increasing the percent of people who get a response to lupus nephritis up to around 80% or better. Very, very good response rates. And another new thing we're looking at is ustekinumab, which in a recent abstract was shown to be effective in lupus patients who don't have nephritis and better than standard of care. So we should keep our eyes open for all of these new things coming along, and there are many more I don't have time to discuss. But the cap on what I want to talk about is, are we going to have a crisis in physicians who know how to use this? Because there is a big problem with physician burnout. There are 2 articles in the New England Journal of Medicine about 2 weeks ago that show that 53% of today's practicing physicians have symptoms of burnout, and half of those will drop out of seeing patients sometime over the next decade. That means we're going to lose 1 out of every 4 physicians practicing today because of this burnout. The Institute of Medicine has defined it as a crisis. There are many groups who fund health care who realize it's a crisis, and many groups are being formed to try to address the solution to this crisis. If anybody asks you to participate, please help.